your other hand to kind of lip the perineum over the fetal head. And I find that that works just as well as just about anything fancy. Once the head is delivered, woohoo, everything's exciting, and this is where you kind of have your panic moment. This is where you're like, oh, what do? I have other things I need to grab. Now, there's been debate about what to do immediately after the head is delivered. Now, for years, we suctioned the mouth and the nares after the delivery of the head. Now, we thought this was especially important when meconium stain fluid was present. Our hopes were to decrease the risk of meconium aspiration. Well, studies haven't shown any real benefit to neonatal suctioning on the perineum. DITLAB6 suctioning at the perineum did not decrease the rate of meconium aspiration syndrome. So in addition to this, there's actually no reason to suction the baby at all, even after delivery of the body, unless there are signs of respiratory obstruction. Now, you still need your bulb suction and DITLAB6 handy, but there's no need to suction a vigorous crying baby unless you see those signs of respiratory obstruction. Next, we check the neck. So that baby's sitting there, check the neck for any umbilical cord. So it might be wrapped around that. Sometimes you can get one or even two wraparounds. And if you can, try to reduce it. Try to loop that around the head. Try to get it out from being wrapped around the head. If you can't reduce it, then you have two choices. If you're supremely confident that delivery of the rest of the body is imminent, then you can actually clamp the cord right here and cut it. And then, of course, you need to deliver that baby relatively quick because that baby is maybe not breathing yet on its own and it's stuck in a mom. So you need to deliver that baby really quickly. If you're not so confident, then you can attempt to deliver the baby with the nuchal cord intact. And I would say that probably is, if you can get it out without feeling like the baby's stuck in there, that's probably the way I would go, unless you get a feeling that that's so tight that it's either causing significant damage to the baby or if it's actually holding back the delivery. All right, so next, that head is out, you've checked the nuchal cord, and now you're ready to deliver the rest of this baby. And this all takes very little time. You're not sitting there for 5 minutes kind of playing with the cord and that sort of thing. This should happen over a couple of seconds because that mom's going to want to get that baby out. So you're going to put your hand on sort of each side of the baby's head. You're going to cradle it. It's not a grab the head like you're in a wrestling match. You want to gently hold that head. Try to get your hands in as best you can on the shoulders. And then you're going to use a gentle, at first, gentle downward traction to help slip the anterior shoulder under the pubic symphysis. So it's this sort of, you're grabbing everything, you're kind of lipping that shoulder underneath. After this, if you get that shoulder out, it's a done deal. That posterior shoulder will come out very, very quickly and the rest of the baby will follow as well. Be careful, because when that anterior shoulder gets delivered, the baby will come shooting out sometimes, and these are slippery little boogers. It never looks good to have to pick a baby off the floor. So be careful, have some towels around you, hopefully so you can grab that baby, because as soon as you do this, you might very well get a big baby coming out at you slippery fast. Hello boys and girls, I'm Dr. Lewis, and welcome to Lou's Clues, the show where we learn about medical stuff. Let's get started! Yay! Today I have a special guest. This is my daughter Hannah. Say hi to the boys and girls at home.
Hi!
Hannah is here to help us learn about a special topic. Are you ready, Hannah?
You bet!
Great! So Hannah, when a baby needs to come out of a mommy's tummy, what are the 3 important things we need to think about?
The 3 P's!
That's right. What's the first P?
Power!
You bet, Hannah. Power represents the strength of the contractions. Without strong and consistent contractions, that baby isn't going anywhere. What's next?
Passenger!
That's right again. Passenger refers to the baby. If that baby's too big, then it might not fit through the mom's birth canal. Hannah, you weighed 11 pounds, 4 ounces. Yeah. It looked like you could eat all the other babies in the nursery. What's next?
Pelvis!
3 for 3, Hannah. If the mom's pelvis is not big enough, then again, that baby can't get through. If labor can't progress due to either the baby being too big or the pelvis being too small, then we call this cephalopelvic disproportion. Can you say that, Hannah?
Nope.
Hi, I'm Dr. Mike McInnes, and I'm here to go through the answer to the quick review in your study guide. Let's go ahead and get started. First question, A 29-year-old G3P2 patient is in the active phase of the first stage of labor. She's currently on Pitocin to help augment her labor. The continuous fetal heart rate monitor has recorded a late deceleration. What simple measures can immediately be taken to help this situation? So remember, late decels indicate utero-placental insufficiency. The placenta isn't getting enough blood or the baby isn't getting enough oxygen. So what you can do, you can stop the Pitocin. The mother should be put on face mask oxygen. And the mother should turn onto her left side to decrease the inferior vena cava compression to increase uterine perfusion. Next, a 31-year-old G2P1 patient is in active labor when she has 6 contractions in a 10-minute span. What's the diagnosis and what can be given to the patient to help relax the uterus? So the diagnosis is tachysystole. This diagnosis is made with at least 5 contractions in a 10-minute period. And you can give terbutaline to relax the uterus. Next, what are some indications for episiotomy? So episiotomy is done in deliveries with a high risk of severe perineal lacerations, or if there's soft tissue dystocia, or if you need to facilitate delivery of a possibly compromised fetus. Next, how long does the first stage of labor last in a nulliparous and a multiparous woman? So in a nullip, the average is 10 to 12 hours. In a multip, the average is 6 to 8 hours. Next, a 23-year-old G1P0 patient has dilated to 5 centimeters and is at 50% effacement. She has an adequate contraction pattern with over 200 Montevideo units, but her cervical dilation nor her effacement have changed in over 2 hours. What is her diagnosis? So this is active phase arrest. So that's the end of the quick review. Let's go back to Dr. Lewis.
All right. Third stage of labor begins after the delivery of the infant and ends with the delivery of the placenta. So we got the baby out. What do we do now? So suction that airway again. Make sure that there's nothing gargling in that throat as best you can. The next thing is probably, though we'll talk about some debatable issues here, clamp the cord. So you're going to take that cord, you're going to find 2 places, clamp, clamp. Where do you cut? Clamp between the cut between the clamps. I hope it doesn't happen to you, but it always happens to somebody in your residency where they're cutting in the wrong place and then blood goes everywhere. It never really looks good to hand a baby to the mom with a shower of blood kind of going everywhere. So cut between the clamps. And if you're going to have dads or someone in the family cut, make sure you tell them exactly cut here, because people will be excited and people just panic. They've never been in this situation and they're trying to pass out and cut a cord at the same time. So be very obvious, like hold it up like this is where you cut. And then they'll be able to do that. Now, when would you not want to cut the cord? Well, there is some evidence that delayed cord clamping can be beneficial to the baby because more blood is transferred from the placenta to the infant. Now, this has some potential value. Now, this can decrease the rates of neonatal anemia, but on the negative side, it can also increase the rate of polycythemia and neonatal jaundice. So there's a little bit of a debate right now. I don't think there hasn't been clear evidence that one is drastically better than the other ones. But if you have a patient who says, hey, look, I don't want you to cut the cord right away, don't feel bad about that. There's probably no serious harm that can be done, though, like I said before, there is a slight increase of polycythemia and neonatal jaundice theoretically. Next, dry that baby with towels. So babies will lose their heat very, very quickly. They'll get very cold. So you want to dry them really, really good. And that agitation will kind of get them to open up their lungs and start crying a little bit. If you can remember, if you watch TV, they used to hold the baby upside down and slap it on the butt. We don't really do that anymore. But just sort of vigorous drying and warming will irritate that baby enough to get it to really open up its lungs and start crying and be vigorous. So you're probably not going to get too many good looks if you're whapping babies on the butt anymore, though maybe somewhere they still do that. Finally, early interaction between mom and baby should be encouraged. Sometimes we whisk babies away off to the corner and then, 20 minutes later they bring the baby back over. Now you have to play this by ear. Sometimes moms are just exhausted and can't deal with this. But most of the time, skin-to-skin contact is great for early initiation of breastfeeding, trying to get the baby on there and suckling as quickly as possible. It serves lots of purposes there. One, just the bonding experience is really, really great. Also getting the breastfeeding started, because that's very beneficial and also will help with some uterine contractions and stopping postpartum bleeding as well. But obviously, make sure the baby's not in trouble. If the baby's blue and not breathing, then you probably don't want to hand it to mom. You probably want to make sure the baby's okay first. So be aware of that. Cord blood. So cord blood is collected prior to delivery of the placental if you can. So cord blood may be tested for blood type and RH. So that's real important, especially if you're worried about incompatibilities of blood, that sort of thing. And next we deliver the placenta. So there are 3 classic signs of placental separation. Number 1, lengthening of the umbilical cord. Next, a gush of blood from the vagina signifying the separation of the placenta from the uterine wall. And you get a change in the shape of the uterine fundus from sort of a discoid to a globular shape with elevation of the fundal height. So the placenta always seems bigger than it should be. You know, when it comes out, you're like, holy moly, this thing's huge. Now, there's 2 major approaches to delivering a placenta. There's the expectant management, and this is passive and consists of delivering the placenta without the use of uterotonic agents, cord clamping, or cord traction. And then there's active management. This consists of early cord clamping, controlled cord traction, and administration of a uterotonic agent like oxytocin. And this is given before or after delivery of the placenta to reduce the risk of uterine atony and minimize the postpartum blood loss. Either way is probably not necessarily huge in this process because you will have some moms that are real sensitive about not wanting someone yanking on their placenta. But there was a Cochrane review in the year 2000 that found that active management was superior due to reduced risks of maternal blood loss, postpartum hemorrhage, and prolonged 3rd stage of labor. So there is some evidence out there that the active management does have some benefits. But be careful with your cord traction. Cord traction should be done in a certain way. So an abdominal hand, so you've got your hand on the mother's abdomen, needs to be securing that uterine fundus. You don't want to just be, playing tug of war with the placenta. You've got your steady traction, but you also want to hold that uterine fundus there. You do not want to invert, pull out the uterus. That is a huge, 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 huge deal. Blood will go everywhere, and you will need all sorts of people to help you, and surgery will be needed. So make sure you don't pull out the uterus while you're pulling out the placenta. As the placenta emerges from the vagina, you'll see membranes kind of trailing behind. One way to kind of get all those membranes, slowly rotate the placenta, or if you are coordinated, you can graft those membranes with a clamp and kind of pull them out all at the same time. Do not do a lot of ripping. You want to do very easy pulling out of all those membranes. And this will help to keep those membranes from being retained in the uterine cavity. It can lead to some extra bleeding if you got some membranes kind of stuck right there in the cervix. A retained placenta is a placenta that has not delivered within 30 minutes after the baby. Now, you can remove it by manual extraction. It's not very pleasant. It kind of hurts. Though be aware that a retained placenta can be a sign of placenta accreta, where the placenta has invaded into or beyond the endometrial stroma, so that's a big deal. It might require surgery, probably will require surgery actually. The placenta, the umbilical cord, and the fetal membrane should be examined. You want to make sure there's no giant chunks missing out of that placenta, because that could mean that you have retained placenta and can lead to bleeding. Average blood loss in a normal pregnancy is about 500 milliliters. We do have a lecture that's going to talk about postpartum bleeding, so we're not going to talk a lot about that right now. Next, the cervix, vagina, and perineum should be examined for lacerations. This will take some training. You need to have someone show you how to do this stuff, and then you need to practice it. Perineal lacerations are the most common, and we do these by degree. First degree involves the mucosa or skin. Second degree extends into the perineal body. Third degree extends into the anal sphincter, and fourth degree extends into the mucosa. So fourth degree is a big one. Interrupted sutures can be used for first degree tears, and then second degree and beyond are usually repaired in layers with running sutures. And again, we're not going to go through all of the many myriad of ways of repairing second, third, and fourth degree stuff. That's great as a hands-on or as to watch a video dedicated just to that. The fourth stage of labor is the 2-hour period after the delivery of the placenta. The mother's body is going through significant physiologic adjustment at this time, so very, very important. So let's recap really quick. We've got our first stage. It's divided into two phases. You have your latent phase and your active phase. You're dilating that cervix. You're going from 0 to 10. Then you get into your second stage of labor. You're pushing, you're doing all the right things.